All right. Now, one of the things that a lot of people don't think about but is important is positioning. And when you're doing an exam, a cardiac exam, you want your patient back on the table. I've already got the head of the table raised. So what I'm going to do is say, can you go ahead and lie back? And pull, always pull that out to make your patient comfortable. What side of the table am I standing on?
Right.
Okay. I've done my observation. So I don't have to check her jugular venous pressure at this point. So next is what? You remember? It's palpation. We don't percuss generally on the cardiac exam. It's just not particularly useful. So my next job is to find her point of maximal impulse, her PMI. Now, on anybody, the PMI in a normal person is going to be at about the 5th intercostal space in the midclavicular line. And I put my fingers down there and I feel a very nice PMI. So those of you who are working with Lauren will find her PMI without any difficulty, okay? And most of you, you can find the PMI. Notice I'm not touching her breast. And what I would do in the room is say, I'm just gonna slide my finger up, usually under their shirt. I asked her to take her shirt off to make this a little easier for you guys to see. But I'm not on her breast. I'm at that line that's essentially the underwire line, okay? It's the line just under the breast, is about the 5th intercostal space, and again about the midclavicular line. So nice PMI, about the size of a dime, is normal. It's not displaced. If I didn't find it there, but I found it out here, that would suggest to me that that left ventricle was enlarged and that it was pointing all the way out here instead of being relatively vertical. If I don't find it out anywhere along there, I come in a little more medially, and sometimes I'll find it closer to the sternum, and that's sometimes the case when people have more vertical hearts. So sometimes people with obstructive pulmonary disease like asthma and COPD, because their lungs are hyperinflated, their heart is kind of pushed into a more vertical position. But sometimes it's normal. I mean, there's a huge variation. So in a young, healthy person with a PMI a little closer to the sternum, I'm just going to say it's a little medial to the midclavicular line, but I'm not going to get all excited about it. Okay, then I'm going to say, I'm going to now feel for enlargement of your ventricles. So it's going to mean my putting my hand on your chest. Are you okay with that? Mm-hmm. All right, and then I'm feeling here. Now my heel of my hand is over her tricuspid area. The ball of my finger is over her mitral area. So if there were thrills or vibrations from those valves, I'd feel that. But also, if her left ventricle was enlarged, I might feel that. And she probably would have had an enlarged PMI. And that's a heave or a lift. Same thing. Okay. And then I'm going to do that. And now the ball of my thumb is over her tricuspid area, and my fingers are over her pulmonic area. I don't know why I'm stuck on that this week. And I might feel a thrill, but if her RV is enlarged, I might feel a lift. And then finally, I feel over her pulmonic and aortic areas for thrills. So I'm feeling for lifts or thrills, but I don't say that. I don't say heave. I don't say thrill. I say I'm feeling to see if your heart's enlarged. Okay? If I hear you say that, I'm going to know that you're also feeling for thrills. Would you agree with that?
Yes, it's
Yeah.
probably.
Yeah.
Let me see if I feel a thrill.
Yeah, it's just never, and I've heard people say it. I've heard people say it in the clinic. And you know, the patient's eyeballs will sort of pop out of their head. Okay, so now I've observed, I've palpated. That didn't take as long as it takes me to talk, you know. It's this. I'm going to feel for your heartbeat on your chest. Now I'm going to feel your chest to see if your heart's enlarged. Are you okay with that? My hand's going to be under your breast and then between your breasts. Okay, good. Now I'm going to listen. And I put on my stethoscope, facing forward. You all know that, right? Okay. And I have a tunable diaphragm. And I'm going to be listening in 4 different places. Just breathe normally. And you need to say that because people are used to taking deep breaths, right? So you need to give people clear instructions. Sorry. And then locating the angle of Lewis, the second intercostal space is just above and lateral to the sternum. And I'm listening with light pressure, aortic, and firm pressure. And I'm listening through several cycles. And my head is engaged. So I'm hearing lub-dub. I'm not hearing any other sounds. Okay? I'm listening for things like, is it a normal rate? Which you've probably already checked with your vital signs. But are there any irregular beats? Is it going lub-dub, 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 which I would say is regularly irregular? Or is it going lub-dub, 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 right? You know, so that might be irregularly irregular and might be a suggestion of a certain condition. Does anybody know what causes an irregularly irregular heartbeat? AFib, good, atrial fibrillation, okay? So I've used light pressure, firm pressure. I move on to the pulmonic area, light pressure, firm pressure. And again, usually on women, if they're wearing loose clothing, I'm going to slide down from the top. Then I'm going to say, I'm going to slide up under your shirt. Is that okay? And I'm going to find the tricuspid area, which is about the 4th intercostal space. Light pressure, firm pressure, brain engaged. And then I'm going to move over to the mitral area or the apex. Light pressure, firm pressure. Okay, and then finally, go ahead and roll up on your left side for me. And I'm going to listen in that same place again. And you can actually keep your stethoscope there while you have them roll. And now I'm only using light pressure. Okay. The reason that I'm only, thank you, sweetie, sit up. The reason that I'm only using light pressure is because I'm only listening for certain low-pitched sounds. So what are the low-pitched sounds we talked about in lecture yesterday? Gallops, which are S3 or S4. And there's another low-pitched sound that we're going to listen to there. This is the mitral area and the murmur of mitral stenosis. So remember that stenosis is when the valve doesn't open all the way. So the murmur of mitral stenosis is a rumble. It's a low-pitched murmur. Would you imagine that that murmur occurs in systole or in diastole? Think about it. When is blood flowing through the mitral valve? Diastole, exactly. So the murmur of mitral stenosis is a low-pitched diastolic murmur. Tends to happen relatively early in diastole when the valve first opens and there's kind of a lot of passive blood flow. So that's when I'm talking about engaging your brain through this whole exam. You need to be engaged. You're not just going through the motions. You are thinking light pressure, low pitch sounds. I'm hearing S1, I'm hearing S2. I'm not hearing anything else. Okay? Firm pressure, high pitch sounds. Okay, S1, S2, I'm not hearing anything else. And then you move on to the next spot and you do the same thing. Suddenly you get to the tricuspid place and you're hearing lub stub, lub stub, lub stub, and you go, I'm hearing something else. What is it? Is it systolic or diastolic? It's systolic because it's between S1 and S2. Okay, where am I hearing it? At the tricuspid area. What is its shape? It is from lub to dub. It is a holosystolic murmur that's not changing in loudness. What might that be? Okay, so it's...
Splitting of S2?
Pardon?
Is that the splitting of S2?
No, it's shh, shh, shh.
Turbulence.
So it's turbulence, and in this case, I'm hearing it at the tricuspid area. It's happening during systole, but it's not getting louder and softer. I'm thinking that this might be that the tricuspid valve isn't closing all the way, which would make it tricuspid regurgitation or insufficiency. Okay? So if you are able to think as you're listening, you'll be able to actually make, not a diagnosis in the current era. In this case, the diagnosis is ultimately going to be made by echo. But yeah, you can make that diagnosis. And I'm going to tell you that someday you may end up working, being on a mission trip or working in a less well-resourced medical system where you don't have an echo available, and in that case, yeah, it's your exam that may be making the diagnosis. So thinking about I'm going to go back to let's take aortic valve. When I'm listening to the aortic area, I hear lub, shoo, dub, lub, shoo, dub, lub, shoo, dub. Okay, so it's systolic. It's getting louder and softer. And then I go, so this is the aortic area. It's systolic, so it must be aortic. I am hearing people whisper stenosis because it's systolic. So when the ventricle is pushing blood across this abnormal valve, because it can't open all the way, it's making this crescendo decrescendo thing. So then I think, well, gee, I wonder if I could hear that in the carotid. And I'll take my stethoscope and I'll put it on the carotid and I'll go, yeah, it radiates to the carotid. And then I know this person has aortic stenosis. And then I might have some questions to ask them because there are certain symptoms that go along with aortic stenosis and maybe I haven't asked them before. Or maybe this is a person who came in because they passed out, they had syncope. And now, just from my physical exam, I have determined one possible cause of syncope. People with aortic stenosis sometimes become syncopal. Okay, so these are exams that if you keep your brain engaged, you can actually become expert diagnosticians. That's what the physical exam is really about. And a lot of people in an era of technology have just tossed that all out the window and they go through the motions. You know, you'll see surgeons who was not really surgeons. Surgeons will listen carefully to the belly. Okay. But you'll see, say, an orthopedic surgeon or a urologist. They'll go for about that long, and that is their heart, lung, and belly auscultation. Okay. And you look at their chart, and it will say, you know, lungs clear to auscultation, cardiac, regular rate and rhythm without murmur.
They're good.
Normal bowel sounds. I mean, seriously, I'm not exaggerating. Is that exaggerating,
No, ma'am.
Dr. Oxendine? That is not exaggerating. Don't be that person, because it only takes a couple of minutes to actually do a really thorough heart and lung exam. All right? And you may pick up something really important. So now what I'm going to do, the other thing that I didn't mention as part of this exam, and we'll talk about pulses more next week, but it's very reasonable to check when you're palpating the carotids on both sides. You do them separately, not together. And when you're auscultating, to listen for bruits over the carotid arteries. So what I'd like you to do now is in pairs or threes, yes.
Have some tips for them, like when there's
Yeah.
extraneous noise in the room,
Ah.
exam room, and
Okay.
how do you keep your brain engaged when people are talking, kids are running around?
Suggestion?
Close your eyes.
Mm-hmm.
That's one thing I would always do. Close my eyes. My eyes didn't see so my brain just heard, and my mind saw the heart.
Good. And you can ask people, just be quiet for a minute. I'm listening. I mean, what's really awful is here you are, you're listening, and your patient's like, what are you doing now? So say that to me.
What are you doing?
Which I hear, and I'm like, I'm sorry, I'm listening to your heart right now. We'll talk in a minute.
So if, especially like when we're in clinicals and we're new and we're hearing something that we either don't know what it is or we can't find it or doesn't sound right, how do you want us to handle like getting a preceptor for help or something like that without freaking out a patient? Like, I don't know what I'm hearing in your heart. I'll be right back.
You just say, I'm gonna go talk to
Yeah,
my
just say I'm gonna go
preceptor."
talk. I mean, after the exam, you say I'm gonna go talk to the preceptor and we'll come back.
Yeah.
Okay.
Okay.
I mean, if they're alive and they're not blue and they're not hassling for breath, it's probably something that will keep until you walk out and talk to the preceptor, right?
All right. You can put your shirt on. Thank you. You're a good sport.
Of course.
Gladys, come here.
Oh,
Okay. Here's Gladys. She's completely dressed. How do I do this? I say, first go ahead and lie back because this is done supine. I say, I'm gonna be listening to your heart, and that's gonna involve me sliding my stethoscope, all right? So I'm gonna start by feeling, so I don't have to see her chest to do that. Now I'm gonna be feeling for enlarged ventricles. And now I'm gonna be listening, and my stethoscope is gonna be coming down under your shirt. And asking, and for the tricuspid, you can either go down from above or up from below. And for mitral, you always come down from below, and you're just under that bra line. And go ahead and roll up onto your left side for me. That's perfect. Good.
how about when you were
Yeah. So when you have a woman who's very large, right? What I do is say, would you take your hand, and I might put their hand, go ahead and lie back again. Would you take your hand and just pull your breast up out of the way so that I can listen? Okay, so I didn't have to do it. And now I'm gonna slide up under your bra. Is that okay? Anything else that you can think of?
The other thing, people who have like a lot of adipose tissue, the heart sounds can seem so distant.
Yeah, yeah, definitely. So big people, you may have distant heart sounds. What you do then is you honestly record distant heart sounds, or, you don't, you say no murmur heard, but you make sure to note that the heart sounds were distant. Yeah,
I have kind of a weird question. Would a breast augmentation change the sounds?
not at all.
Okay.
And then the other people in whom sometimes it's very hard to hear heart sounds are people with bad COPD and a lot of air trapping. There's just, that it's insulation, right? So it can be, and again, you would do your best exam possible. You make sure that the conditions are as comfortable and conducive as they can be. And then you record what you actually heard with a comment that it was a difficult exam with distant.
With a lot of adipose, did you ever have them lean forward just to try to bring?
I've done different things, but I haven't found a whole lot. Yeah. Now sometimes, if you suspect pericarditis, so somebody's got chest pain that is probably relatively sharp in nature, there's a finding called a friction rub, and that is best heard with the patient leaning forward. It's kind of bringing the heart and the pericardium closer to the surface. And those are the same people who probably feel a little better leaning forward too.
What does that mean? What is the friction rub?
It's exactly what it sounds like. When people have pericarditis, they have inflammation in the pericardial sac. So there's inflammatory stuff going on inside the pericardial sac and on the pericardial surface of the heart, and it's rough. And it actually sounds sort of like leather rubbing together.
So you hear it with the beat?
And you hear it with the beat, and it usually has, the books say it has 3 components. So it's sort of murmur-like, except it's a little harsher, and it sounds, it's going with the heartbeat, but maybe with both lub and dub, and maybe a little extra in there somewhere. And so you can't identify it as systolic or diastolic, because it's, yeah. I'm thinking.
Oh my God.
Yeah. Now, 99% of the time, not quite, but much of the time you're going to have a normal exam. And I will tell you that a normal cardiac exam does not preclude serious cardiac pathology. There are tons of people in the middle of an acute left ventricular anterior wall infarction who have a normal exam. Okay, they may be a little sweaty. That's not normal, but it's not really part of the heart exam. Okay, but they may have sinus rhythm without any abnormal sounds. So don't be, it's this, and there are people, and I've seen this, there are people in the middle of an MI who have normal EKGs along with their normal exams. My world as an urgent care provider, I realized quite early on that the first thing to do if I was seeing somebody in whom I suspected cardiac chest pain was to call 911 and then get oxygen and aspirin, okay, and then get somebody to grab the EKG machine and somebody to start an IV. And it was more important to me to have a good IV started than to have the EKG. So that by the time the EMTs got there, I had done what little can be done in a primary care setting. They got the aspirin, they chewed the aspirin, right? They're on oxygen. If I didn't have an EKG to hand to the paramedic, they might roll their eyes, but that
Don't
per
look at me.
no, I mean, I'm not looking at you. I'm just sort of,
Not you, not-
but it
You roll your
that
eyes at Dr.
you know,
Morris.
in my opinion, this person needs to be transported. Once it's on them, fine, take them to the truck and do an EKG, because there are things that they're going to be able to do that I can't do. But it's more, you know, from that standpoint, it's more important to get the paramedics there with their real defibrillator than anything else. So and I knew that if I had normal EKG, I still wanted that person transported if I had a good suspicion.
Did you carry nitro in a primary care setting?
Yeah, we did give nitro in the primary care setting. But I will tell you, one of the things that I saw in a lot of our clinics was that people would open the nitro, not date it. They don't use it very often. And nitroglycerin is very subject to oxidation. So after, I don't know, 30 days, the 25 or the 23 little nitro pills left in the vial are dead. So part of my job as a medical director for a chain of urgent care clinics was coming up with SOPs and making people follow them.
That's why we carry spray on an ambulance. because
Yeah, and in
it's
fact,
not
we ended up
sensitive.
I had to talk, spray is a whole lot more expensive, but it doesn't degrade to the same degree. So I finally managed to talk management into spending the money for the spray instead of the pennies it cost for the bottle of pills. But before that, I made sure every clinic had to have first they had to date and toss and all that, but also they had to have an unopened, a sealed bottle, so that if the pill didn't immediately give the person a headache, basically, they were to open the unopened bottle and proceed with a fresh supply. So, alrighty. So, what time is it? I don't know.
9:17.
Okay, so for the next half hour, what I'd like you to do is disperse in twos, and I want you to practice, and I want you to practice a few times going through that sequence of the exam, because again, this is about physical skills that need muscle memory, okay? But while you're doing it, engage your head. Are there any of you who know you have a murmur?
I've been told I have one.
I was told, and then I had an echo and said it was normal, so I don't know where that leaves me.
Okay, so I'll come listen to you, and if I hear a murmur, and you too? Okay. If I hear murmurs, I will ask you if you'll let other people listen, okay? Alrighty.